Thank you very much. I'm Fahad Nikolian, and today I'm honored to speak to all of you in India about the concept of preoperative optimization. This is something I'm very passionate about, and I think it's critical, especially in patients who have loss of domain. In terms of disclosures, I serve as a consultant for Care Syntax, Medtronic, and Intuitive, though none of these are relevant to today's discussion. So why do we optimize? The bottom line is that outcomes following ventral incisional hernia repair, even in scenarios where there isn't loss of domain, are not that great. And as we watch, we see that patients who've had recurrences have a higher burden of recurrence and time to recurrence than those who have had less operations performed on their abdominal wall. So what does this tell us? Our opportunity for success is best with our next operation. So we have to do everything we can to improve outcomes for patients even before the incision. The burden of ventral incisional hernia is real. Up to 40% of patients who have an incision on their abdomen will develop a hernia. This translates to almost 500,000 ventral incisional hernia repairs in the United States alone. Unfortunately, outcomes aren't that great, even though it's such a commonly performed operation, with recurrence rates up to 40%, complication burdens that are very high, and readmissions for as many as 13% of patients. This translates to billions of dollars in GDP that we invest here in the United States on management of patients with incisional hernias. Unfortunately, this is a cycle that many of us have witnessed. A patient comes in with a hernia, undergoes an operation, potentially in a suboptimized setting, suffers a complication, which then translates into a recurrence. And then the cycle continues over and over again until they end up with a scenario like many of the ones that we're discussing at today's conference, loss of domain. So with that said, we have to recognize that there's opportunities to optimize. And our goal is to do the operation on the right patient at the right time, and then select the correct technique to maximize our outcome. Preoperative optimization is not a new concept. I think for many of us in abdominal wall surgery, we think of the big three: diabetes control, weight loss, and smoking cessation. And we're going to dive into those shortly. But then clearly there's other opportunities that we'll review as well. For instance, infection control, improving patient exercise tolerance, optimizing their preoperative pain regimen so that their postoperative regimen could be a little more manageable. Hopefully working with patients to ensure that they have alcohol cessation. And for patients with things like sleep apnea, working to manage that so that their pulmonary mechanics are optimized as well. Our goal is to optimize optimization. And in an ideal world, every patient would be optimized. But unfortunately, the truth of the matter is that we can't necessarily get everyone there. There are going to be high-risk patients that we're going to be obligated to operate on. Patients who are active smokers, who have active infections, who have loss of domain, patients who have multi-recurrent hernias, or who are malnourished. Though these patients present challenges in terms of getting them to this concept of optimization, I think every patient has the potential to be in a better state than they are when they first present to us in clinic through a process of education. Clearly, loss of domain is not very conducive to minimally invasive approaches. So for many of these patients, skin and soft tissue complications can really impact our operation. I think it's important to objectively define risk. There's no absolute right answer in terms of the perfect risk stratification tool. Clearly, many of them exist. But as a hernia surgeon, I personally like to use the CEDAR application out of the Carolinas Medical Center and Dr. Hennifer's group. I find that it gives simple numbers so that patients can objectively see what the risk profile for their operation is. Further, I like to manipulate the numbers and demonstrate to them, this is what happens if you quit smoking, you reduce your weight, or you get your diabetes under better control, look at how your risk profile significantly decreases and hopefully motivate them to engage in optimization strategies. Let's start with some opportunities for optimization. Smoking cessation, very commonly discussed. Clearly, it does demonstrate in many studies, not just in the hernia literature, that there's increased rates of SSIs, recurrences, and readmissions. And so at our center, we target 4 weeks of abstinence in advance of an operation. What does this mean? We're okay with patients having nicotine replacement. We're okay with patients having lozenges, gum, patches, whatever they want to do. We just want 4 weeks of no smoking. And we test for this with serum testing for nicotine and metabolites, which allows us a little more granularity of the data so that we can really interpret and confirm, is it just nicotine replacement therapy or are they still actively smoking? I will say that this has become somewhat more controversial. Some more studies are coming out of places like the ACHQC, looking at what happens to patients who are actively smoking following abdominal wall reconstruction and ventral hernia repair. This was a study that came out of the ACHQC, formerly known as the AHSQC, and demonstrated at least at up to 90 days, outcomes were essentially equivalent for smokers and non-smokers, though long-term outcomes data is lacking. Management of obesity, yet again, another opportunity for improving patient outcomes. Many patients who have loss of domain have challenges with their physical activity level. They also oftentimes have issues with their metabolism. And so many of them present to our clinics and are considered obese. It doesn't change the risk profile. You take a very risky operation and then you add obesity on top of it, you can really have some bad outcomes. So it's important to recognize that obesity alone in ventral incisional hernias is associated with high rates of SSI, pulmonary complications, blood clots, and readmission. So it's on us to work with our patients to really define goals. And a BMI of 35 is the optimum. Clearly, many of our patients won't get there, but I look at this as the goal. And my goal, especially for patients who are presenting with BMIs in the 40 to 50 range, we want to work to get the trajectory of their BMI towards 35, as it can really modulate the laxity of the abdominal wall, the compliance, and reduce the visceral adiposity that may impact our ability to close the abdomen. Diabetes control is something that I consider to be a straightforward and simple fix. And so there's really no reason why we shouldn't target good diabetes control in advance of an operation. Poorly controlled diabetes at the time of surgery can result in higher rates of wound complications and perioperative complications, which can translate into bad outcomes for patients who are undergoing procedures for loss of domain. In my clinic and our institution, we're targeting hemoglobin A1C 6.5%. For patients who are presenting with multiple risk factors that are suboptimized, I have never had a situation where we have not been able to get diabetes under control with a simple email to a primary care physician or a referral to an endocrinologist. So again, a straightforward target that we could definitely get close or if not below 6.5. Prehabilitation. A lot of data, it's become very popular, but the truth of the matter is prehabilitation has been around for a very, very long time. Our goal is to offset the effects of the surgical insult, the catabolic effects, the tissue trauma, the quasi-starvation state that the patients are in, and the relative inactivity that they'll have immediately after the operation. Our major goals are to enhance physical conditioning, reverse the deconditioning, and increase functional reserve. Prehabilitation falls into 3 adjuncts when you're thinking about how to get the patients to where they need to be. It includes physical exercise, psychological support, and nutritional optimization, at least in our program. Physical exercise and strengthening, again, our goal is to get a baseline assessment. This can be very simply done cost effectively by asking a patient to walk 10 feet, as little as 10 feet, and time it. You're able to get your sense of their baseline. You're also able to ask them to walk up a flight of stairs and observe it. And if you can't observe it, have your nurse observe it and time it. And again, that will give you a good sense of their baseline physical sort of health. Our focus is endurance and cardiovascular exercise to increase functional reserve, though we do allow and support patients who are interested in strengthening exercises as well. Physical exercise and strengthening can be done in a variety of ways. There are cost prohibitive approaches as well as cost-effective approaches. You know, not every institution is going to have the ability to collaborate with physiotherapists and get patients in a very engaged prehabilitation 4 to 8 week program. That's clearly not going to work for everyone. And especially in places where patients have to travel long distances to medical centers, this may not be a realistic goal. But there are cost-conscious recommendations. One of the best things any patient can do in advanced surgery is get those step counter and start walking. I tell my patients, walking is your best opportunity to improve your outcome following AWR. One of my senior colleagues who takes care of a large proportion of socioeconomically challenged patients recommends canned food as the weights. And so everyone has canned food in their pantry. We tell them, go ahead and use those as your simple 1 to 2 pound weights to help strengthen your arms and legs and do simple body weight exercises. I also refer my patients to the ACH QC Patient Mobile app. It has a nice little program to help patients prepare for operations. Prehab, is there data? Of course there is, tons of it actually, and it's been around for decades. Again, it's become more popular of late over the last 10, 15 years, but prehabilitation has been in the literature for now over 70 years. And in many studies has demonstrated faster rate of return to pre-op functional status, decreased complication burden, decreased length of stay, and has demonstrated improved postoperative function as well. Immunonutrition, especially for high-risk patients, is something that we like. This can be cost prohibitive. A course of pre-operative immunonutrition shakes can sometimes cost on the order of $100 to $200, so it's not necessarily going to work for everyone. But immunonutrition in GI and cancer surgery has demonstrated SSI reduction, sepsis reduction, as well as even mortality reduction. And it's more than just the protein. It's all the other things, especially like the fish oils and the triglycerides and some of the other elements of these shakes that result in modulation of the immune system and that inflammatory process that occurs after surgery. Psychological support, we're learning more and more the connection between the mind and body. And we work to educate patients, help reduce anxiety, and hopefully this results in improved compliance with our pre-op optimization programs. We collaborate regularly with our psychiatric and psychological services, and our patients have really enjoyed this element of the prehabilitation program. So we've talked a lot about the ideals. I hope that during our discussion, we can talk about the realities and really dive into that. But let's be honest, these things that I just described are resource intensive. It takes a lot of time, it takes a lot of personnel, and it can at times feel like it's cost prohibitive. But one thing I do like to remind people is that complications are even more resource intensive. So work with your teams and find ways to optimize your patients. So in conclusion, preoperative optimization is critical for postoperative outcomes. It takes a multidisciplinary approach to accomplish this, so definitely start making friends around your medical system. And I think proactive preparation can hopefully mitigate retrospective regrets. So with that said, thank you very much for the opportunity to present. I welcome you all to visit us in Portland. This is actually a view outside of our hospital. And we would love to invite you all to Portland one day when the pandemic allows for more simple travel. Thank you again.